Okay, so good morning everyone. I hope you can hear me and welcome all. My name is Dr. Ankit Khandelwal and I am MBBS and MS in Anatomy. And today we have gathered today in this Saturday morning to discuss the important part of our preparation, that is the clinical MCQs from the neuroanatomy part. Okay, so here we are into the clinical MCQs for the neuroanatomy part, and let's start from here. So after the recent slight change, I would say it as a slight change in the number of questions. We are expecting the percentage of the long and the clinical questions to be slightly more than what it used to be in the yesteryears. So we'll focus more in this particular session about a few of the clinical MCQs, and here we start with our clinical neuroanatomy MCQs. Okay, so let us start all of you. Okay, and here we go. Fine. So there are a few important slides which we need to show you, that a very important update. I hope few of you may be knowing. If not, then here it is. There are free grand tests which are going to be conducted by Unacademy on every week. That is on 7th, 14th, 21st, and 28th of March. The timing initially was around 10 a.m., but we are talking so that the time could be changed to the actual time of the exam, which is from 2 p.m. to 5:30 p.m. 2 p.m. to 5:30 p.m. So we are in talking so that we can change the time also, so that you have a general idea in that particular time of the day when you are going to give the exams. So there are 4 free grand tests in the new pattern. Now the main part of that is that this is going to happen on new pattern. This is point number 1. Please make a note of it and book your dates. Okay, the time would, if it is changed, obviously will be notified to you. Another thing for our plus subscribers is that we are starting a course from 1st of March, that is from day after tomorrow. And the name of the course is, you can see, the last mile to crack NEET PG. Now this course of 1 month is going to be an intensive sort of course where all the 19 faculties, 19 educators of the 19 subjects would be dealing with the clinical MCQs and all those latest year or the latest trends MCQs in this particular course. So 31 days, 19 subjects, everything whatever you have read would be very much revised, concepts would be made, whatever your doubts are there, they would be solved. So it's going to be live interactive session, TNDs would be there, specific doubt clearing sessions would be there. There's obviously integrated approach. So in that session, we're also going to conduct few of the dual faculty, where the 2-3 subjects faculties will come and they will try to discuss how to approach a particular integrated MCQ. So that would be there. Finally, there is also tomorrow, guys. Tomorrow Sunday, be ready. There's a revisathon going on. So tomorrow Sunday is 28th of Feb, and tomorrow we would be conducting a test on anatomy subject. And for those who are in their different zone of preparation, like in this particular zone, not mainly giving the NEET PG 2021, but maybe next year, this is a 1 hour 45 questions grand tests, you can say, or subject wise test, every Sunday 5 to 6 p.m. So tomorrow is a Sunday, tomorrow at 5 to 6 p.m. The subject is anatomy, so all the best for that. So they have also scholarships which will be given over here. This is a completely free test. So 1 hour Sunday 5 to 6 p.m. scholarships are given over here. So all the best for that also. Okay. So these are 3 important things. Revisathon tomorrow 5 to 6 p.m. Course from day after tomorrow. Remember, this course for NEET, mainly for NEET PG 2021, guys. And there's a free grand test on 7th, 14th, 21st, and 28th of March. Okay, so these are 3 important things which are just in a couple of days or maybe tomorrow. After that, for those who are targeting mainly INI-CET, again from after day after tomorrow, there's a course from March and April, 2-month course for INI-CET exams. Okay, again the same format. These are all the plus courses. You can note the code down. Code is Dr. Ankit Live. That is the code you can use to avail 10% extra discounts. Okay, so this code you can use, written underneath down over there also. Okay, target for the who are giving next 2022 exams next year. Again, there's a course going to start at 1st of March. So a lot of things going on over here. All the best for that. All the best for all of this. Okay, so let's start our clinical MCQs, and here comes our clinical MCQ number 1. So here we go. The question says that a 32-year-old lady or woman is seen in the emergency department complaining of severe headaches and difficulty walking. She is noted to be lethargic. On CD imaging of the head, she is noted to have enlargement of the bilateral lateral ventricles and the third ventricle. The fourth ventricle is noted to be normal. The most likely obstruction in this patient is where? Out of these 5 options, you can answer in the comment box if you wish to. Foramen of Lashka, foramen of Megendie, cerebral aqueduct, or you can say aqueduct of Sylvius, interventricular foramen of Monro, or cisterna magna. These are the 5 options. Ravi Shankar started with answering. Very good, Ravi. Okay, so in this question, if I highlight the important points, then you have what? Enlargement of what? Lateral ventricles and the third ventricle, but the fourth ventricle is normal. That is enough. These are 3-4 key points in this particular question. Okay, enlargement of lateral third ventricle, fourth ventricle is normal. Where do you think is the obstruction? Simple. So if you look at the ventricular system over here, this ventricular system over here, these are the 2 lateral ventricles. What are these? These are the 2 lateral ventricles in each cerebral hemisphere. These are 2 lateral ventricles. These 2 lateral ventricles will do what? They, through the foramen of Monro, interventricular foramen of Monro, they will enter where? Into the third ventricle. And this is your fourth ventricle. It is located where? It is located in the cerebellum and the pons in the medulla. So third and fourth ventricle, they are communicating with each other through the aqueduct of Sylvius over here. This is your aqueduct of Sylvius. Fine. Now what was the question? Question said that the lateral ventricles and the third ventricle are dilated and the fourth ventricle is normal. These are D for dilated. These are D for dilated and the fourth ventricle is normal. Now where should the obstruction be? Our common sense should tell us that the obstruction appears like in the aqueduct of Sylvius. Why? Because here there is obstruction, and inside these lateral ventricles you have these what are these? Choroid plexus. These are the choroid plexuses inside the lateral ventricle through the Monro in the third ventricle. So they are secreting CSF, but the CSF is not able to reach the fourth ventricle through the aqueduct. Why? Because aqueduct has an obstruction. Therefore the lateral third ventricle will be dilated, fourth ventricle would be normal, and therefore the site of obstruction, the most likely site of obstruction over here, the answer becomes as our option number C, that is cerebral aqueduct of Sylvius. I hope that's fine. Yeah, very good, Ravi Shankar, you changed your answer. Good. So that was our ventricular system. If you want to look at the ventricular system separately, look at this image, same sort of thing. So obstruction again was over here in the aqueduct, and these got dilated, and this was normal in size because the flow of CSF was in this direction. So the extra CSF, the CSF which was formed, was not able to pass the aqueduct. I hope that is clear. Okay, let us see another one. Here you go. Now clinical question, slightly longer question. Here it comes. 80-year-old lady is brought to the emergency department from an assisted care facility. The woman, who is in a wheelchair, complains of not feeling well, of numbness on her face, and of being hoarse. Hoarse means hoarse voice, although she claims not to have a cold. The examination reveals a loss of pain and temperature or thermal sensation on the right side of her face and on the left side of her body. A lesion of which of the following structures in this woman would explain the loss of pain and temperature on the body excluding the head? Okay, so these are sort of questions which we expect, in your coming exams, in all the future exams. Let us say it like that. Just try to answer A, B, C, D, E. Anterolateral system, that is anterolateral, the same as your spinothalamic system, the same as your spinothalamic tract, because it is present slightly anterolaterally. So you call it a spinothalamic tract or anterolateral system. So anterolateral system on the left or the right, medial lemniscus on the left, or the trigeminal nucleus on the left, or tract also on the left. I hope you got the point. A lesion of which of the following structures would explain the loss of pain temperature on her body? Which side of her body? Loss of pain temperature on the left side of her body. That is the question. So where do you think is the lesion? Ravi Shankar is going B, system on the right side. Sure. Okay. So this is what, let us assume for just a next minute, that this is the foramen magnum, and this is your anterolateral, or we can say the spinothalamic tract from the right side of the body, and that is the left side of the body. Problem was where? Problem was in the left side of her body. So let us also make a midline over here. Let us take midline like this. In the spinal cord, we can take a midline like this. Now the tract. From the left side, this spinothalamic tract, it will take the sensation, pain, temperature, and then it will cross at that point in the spinal cord or 1 or 2 segments above. Now it will rise, it will ascend in the right side of the spinal cord. It will cross the foramen magnum, it will reach the medulla oblongata, and then in the brain stem it will go on like this. Relay then in the thalamus, then it will reach the postcentral gyrus. Now the problem was in the brain stem. Why? Because she was being hoarse, so there is some voice problem. She had loss of pain, temperature on the face also. So it appears to be problem in the brain stem. They're asking you that which side, a lesion of which of the following in this woman would explain the loss of pain, temperature on her body. Body on the left side, she has a loss of pain and temperature, on the left side. Problem or the lesion is in the brain stem, so it is on the right side, and the system pain temperature is carried by this. So well done, Ravi. Answer is our option number B only. That is our answer. Clear? Got this point, everyone? Why? First of all, pain temperature carried by spinothalamic or anterolateral, fine. Second, we have to identify where the lesion is. Is it in the spinal cord or is it in the brain stem? It looks like in the brain stem from here. Clear? Now, moving from here, in the same question, where the lesion was where on the brain stem, where on the right side. Understand that. The same question, the lady was also being hoarse. So here, the hoarseness in this lady is most likely due to which of the following? Lesion of the facial nucleus, hypoglossal, nucleus ambiguous, spinal trigeminal tract, or lesion of the trigeminal nucleus. So you can understand the same, basic question would be of the last one, and then this could be as a new question. After that last line, the question would change like this. So hoarseness in this woman is most likely due to which of the following? Hoarseness of voice is most likely due to which of the following? Yes, try to answer this question. C is what? Lesion of the nucleus ambiguous. Sure? Okay, let us see what is nucleus ambiguous. Nucleus ambiguous is falling under which cranial nerve nuclei column? Dash. Try to answer this. Meanwhile, let me tell you, it is 9th, 10th and 11th nerve combined nucleuses. 9th, 10th, 11th nerve combined nucleus. Okay. And it lies where? It lies in the brain stem. Which part? It lies in the medulla oblongata of brain stem. Point number 1 is that. Nucleus ambiguous is 9, 10th, 11th. Now which cranial nerve nuclei column? Yes, vagus nerve is a part of it. That is supplying what? It is supplying the muscles of palate, pharynx and also larynx. Remember the pharyngeal arches? So this is a nuclear column, cranial nuclear column for the pharyngeal arches. Which pharyngeal arch or which nuclear column it is? It is your spatial visceral efferent column. So as it is supplying the muscles of palate, pharynx and larynx, therefore the lady is having hoarseness. And 9th, 10th, 11th nerve nuclei present where? In the medulla oblongata. Now which side, guys? Lateral side or medial side? Answer this. This nucleus ambiguous is present in the medulla oblongata on which side? Lateral or the medial side? Medial or lateral side? What do you think about it? It is most probably in the lateral side, because medial side normally has the 12th cranial nerve nucleus in the medulla oblongata. So as nucleus ambiguous has 9, 10th, 11th nerve, which are for the parts of the cranial nerve nucleus, spatial visceral efferent, which are from the nerves of the pharyngeal arches. Pharyngeal arches gives rise to muscles also, muscles of palate, pharynx, larynx. Obviously that will help you in speaking. The palate, all of these three structures, palate, pharynx, larynx, they help in speaking. So if these are having a problem, the lady will obviously have the hoarseness of the voice. Hence the answer is this. Yes, Anjali, very good. Spatial visceral efferent. Okay, so there's a whole separate topic, cranial nerve nuclei columns. I've done a special class on that also. You can see on the Unacademy. We have completed that also. So hoarseness was due to lesion of nucleus ambiguous. What I'm trying to say is here you have this question. If you remove this last line and you add that hoarseness, the question changes. So the base question, the case remains like this. You can have different question from that particular case. Now one more. It's the same lady. Again, if you remove the last line. So remember this whole case over here. The lady was brought to emergency. Numbness on her face, hoarseness of voice, right side face numbness, left side body numbness. Okay, so we'll write over here what? Right side face numbness and the left side body numbness, and she also had hoarseness in her voice. That was a some, if you summarize the case. Assuming this woman suffered a vascular occlusion, was a brainstem vascular syndrome, which vessel is most likely involved? A, B, C, D, E. No, Anjali, it is lateral side. Okay, very good. Yes. Is it the ICA, anti-spinal artery, PICA, posterior-spinal artery, or superior cerebellar artery? Look at the case. We have already discussed the case. This is the third question from the case. Try to answer this. A, B, C, D. Which artery do you think would be involved here? Yes. Waiting for the responses, guys. So, as we know that where was the lesion? The lesion was in the medulla oblongata. Medulla oblongata. Medulla oblongata is normally supplied by which artery? It is supplied by the vertebral artery. Yes or no? Vertebral, there are two vertebral arteries. They enter via the foramen magnum. I am writing over a VA for vertebral artery, and this site is let us say it is F dot magnum. And at the medullopontine junction, they will form the basilar artery. Basilar artery. So at the medulla oblongata, most of the vascular supply is coming from the vertebral artery. Now vertebral artery, it will give a branch that would go laterally and behind the medulla to supply the lower and the posterior part of the cerebellum. That artery is known as Dr. Amreen is saying A. Okay, Ravish and Anjali are saying C. That artery is a posterior inferior. So good job, Ravi and Anjali. Answer is this. So that is a PICA. This is the answer. PICA, or you can say PICA syndrome, also known as which syndrome? That is also known as your lateral medullary. Very good. It is on the lateral side of medulla. We just discussed. No, where are these located? These are located on the lateral side of medulla. Which nucleus ambiguous? Why lateral? Because she was having hoarseness in her voice also as a major symptom. So it was probably in the lateral medullary syndrome. Lateral medullary syndrome over here is also known as your PICA syndrome. Lateral medullary syndrome, also known as PICA, and it is due to the artery, that is obviously PICA is posterior cerebellar artery. So try to understand that hoarseness is very important point by which you are able to make the diagnosis. Not just hoarseness, when there are these sensory changes, sensory loss in the mainly pain temperature in the face and the body. The name was anterolateral tract. So the word lateral is still telling you it is on the lateral medullary syndrome. Why medullary? Because hoarseness. So there are two things over here. Lateral, yes, well on. Two things I want to tell over here with taking a few seconds is that when you are solving any brain stem vascular syndrome, because this is a high yield topic, normally one or two questions will come from here, mind it. So when you're solving this topic question, you have to understand that first of all the lesion is lateral or it is medial. First point is this. So considering the past question, if you look at the question, you'll see that there was loss of pain temperature. Those loss of pain temperature, the lesions are mostly lateral. Okay, pain temperature in the body, pain temperature, loss of pain temperature in the face. So first point is this. Second point, you have to look, the lesion is in the midbrain, pons or medulla. So for diagnosing this, you need to know that which cranial nerve is basically involved, because they are different in midbrain, pons and medulla. So in that question, that hoarseness point was telling you that the level is medulla. Okay, level is medulla, and the other points with the hoarseness are telling you it is a lateral syndrome. Point clear? So these are the important points. Now I already taken a session on the brainstem vascular syndromes as a special class. You can have a look at that. Go to Unacademy, search for the name, you will get everything. Clear? Okay, let us see one more long question over here. 67-year-old man is brought to the emergency by his wife. She explains that he fell suddenly, he could not get up and complained of feeling sick. Okay. The examination revealed a left-sided weakness of the upper lower extremities. Left side weakness of the extremities. A lack of most movement of the right eye, and a dilated pupil on the right. Left side body gone, right side eye movements gone, dilated pupil is there. Torchlight, you can check it. MRI shows an infarcted area in the brainstem. The weakness of this man's extremities is explained by damage. Very interesting question. The weakness of this man's extremities is explained by damage to the axons of cell bodies that are located in which of the following regions of the brain. So some axons are involved. Where are their cell bodies located of that axons which are lesioned over here? That is the question. I'm just helping you out over here. Left somatomotor cortex, right anterior paracentral gyrus, right crus cerebri, or right somatomotor cortex. Remember, the weakness is in the left side extremity. Problem is in the brain stem. Okay, try to answer this. A, B, C, D. All the best. Think about it. Read the question twice at least, the last line. Ravi and Anjali, very good. They have started answering. Yes. Remember, you can easily speculate these sort of questions coming in the exam. I hope if you are giving NEET PG 2021 on 18th of April, you can easily understand. Okay. Few of you going with option number D. Shubham and Anjali going with option number C. Let us see. So left side weakness of the extremity, most right eye pupil and right eye problem, left limb problem in the motor department. Problem is there in the brainstem. They are telling you MRI, which explained by damage to the axons of cell bodies that are located in which of the following regions of the brain. Okay, so let us try to understand this. This again is say your foramen magnum, that is the midline of the spinal cord, that is right, that is left. Okay, that is right, that is left. Left side was weakness. So let us imagine this is the this is the brain over here, that is the brain over here, and in the brain what we have a central sulcus. Okay, anterior to it what we have a precentral gyrus. I'm writing precentral gyrus. What comes down from here? You have the corticospinal tract, the pyramidal cells. It is a motor cortex, Brodmann area number 4. Okay, they will come down from here, upper motor neurons. They will come down and down. They will reach the midbrain, then they will reach the pons and the medulla. Yes, in the medulla, what do? Pyramidal decussation. They cross. So here is the pyramidal decussation, but they have not yet synapsed. Now, as they go down, they start to synapse with the anterior horn cells, or you can say the lower motor neurons. So this black is your upper motor neuron, and then let us take this midline slightly above also. This is your midline slightly above. This black is your upper motor neuron, and this green is your lower motor neuron. Okay, so lesion was where? Lesion was in the brain stem. Lesion was in the brain stem. Left side body weakness. So lesion is where? On the right side of brain stem. Am I correct? Lesion where is in the right side of brain stem. Here you have the lesion on the right side of brain stem. This is the site of lesion. Obviously it would be near the midbrain. Why? Because the patient is having problem in the eye, in the eyeball movement, mainly the muscles. The third and fourth nerve which supply most of the muscles are coming from the midbrain. So we can assume that right side brain stem, mainly in the midbrain, is a problem. Now the question says, damages to the axons, fine. Whose cell bodies are located where? Now damage of the axons of upper mode, where are the cell bodies of them? Cell bodies are in the precentral gyrus or not? This is the location of the cell body. Yes or no? Yes. Rahul, good morning. The location of the cell body of the axons of upper motor neuron are where? In the precentral gyrus. Which side? It is on the right side. So the answer over here is right somatomotor cortex. Point clear? Answer is your right somatomotor cortex. So remember, the corticospinal tract is a 2 neuron pathway. It tells you that the cell body upper motor are over here. This is the site of the cell body. Therefore your gray matter, no. What is gray and white matter? Gray is the cell body, and that whole white matter is axon. They're not asking you white matter. They're asking you that white matter axon, where is the master or where is the nucleus of this axon? Nucleus is in the gray matter. Which gray matter? Right somatomotor cortex. So here you have the right cell bodies of the U.M.N are over here. And this side on the spinal cord, this is the site of the cell body of the LMN. We can also call it as the anterior horn cells. Crus cerebri, Ravi, crus cerebri are your axons, bundle of axons in the midbrain. As they're descending down, corona radiata, internal capsule, and then that comes down into the midbrain. We call it as a crus cerebri or cerebral peduncle. Cerebral peduncle. And then it goes down into the pons and medulla, then in the tracts of the spinal cord. Okay, Yes, Anjali, acha, cell body. Yes, that is asking you cell body. I was telling you to read this last line twice. Let us read it once more. Last time. The weakness of the man's extremity is explained by damage to the axons of cell body that are located. So there, that means cell body that are located in which of the following regions of the brain. It is already asking you which part of the brain. Okay. Okay. So same question, if we remove this last line, we change the question. That is how the clinical questions will come. The man's dilated pupil. Man also had a dilated pupil. Look here once again. Lack of most movement of the right eye. Most movements gone, and dilated pupil on the right eye. Okay. So man's dilated pupil is due to damage to which of the following fiber population? Answer. Preganglionic fibers from the Edinger-Westphal nucleus, preganglionic fibers from the inferior salivary tree, ciliary ganglion, geniculate superior. I guess this is comparatively easier compared to the last one. So guys, what is your answer? Dilated pupil will be due to damage to which fiber? Okay, good, Ravi, you remembered. Dilated pupil is due to damage of fiber of which population? Dilated pupil means parasympathetic. Okay, parasympathetic does what? Parasympathetic does the meiosis, or it will constrict the pupil. Yes, sympathetic does what? It will do mydriasis, it will dilate the pupil. The problem was in this patient, the pupil was dilated. So obviously parasympathetic, there is a loss. Parasympathetic is covered by 3rd, 7th, 9th and 10th nerve. For the pupil, you have from the 3rd nerve which nucleus? Very good. A. Haren, you are going with C. No. C is C. Postganglionic fibers on ciliary ganglion. They are apart, but where is the location? Location is the brain stem. Look at the, read the whole question. Location, the infarcted area was in the brain stem. Ciliary ganglion you won't find in the brain stem. What you will see here in the brain stem is your Edinger-Westphal nucleus. Can you understand it? What you see in the brain stem is not the ciliary ganglion. Ciliary ganglion, you are partially correct, it is a ganglion for the same dilatation of constriction of the pupil, the parasympathetic ganglion. But parasympathetic ganglions are close to the organ, so it would be close to the orbit. The lesion was in the brainstem. Fine. Is it clear? Okay. Yes, Tausif and Sarkar, Haren Sarkar. I have got the point. Lesion was in the brainstem. Therefore, the answer is option number A. Inferior salivary nucleus is for the 9th nerve, lesser petrosal nerve. It will be for the otic ganglion, parotid secretion. Geniculate ganglion is for your facial nerve. This is geniculate ganglion, that is again for the pterygopalatine ganglia. Postganglionic for this is for sympathetic. Okay. Okay. Sarkar, the question, if you read back at the question, let us take few seconds, guys, if that is okay with all of you, I hope. Lesion was in the brainstem. The patient had problem in the left side weakness of the body and right eye problem at the dilated pupil on the right. The lesion was in the brainstem. They asking you why is dilated pupil is due to the lesion is where? It has to be somewhere in the brainstem. Ciliary ganglion is a parasympathetic ganglion that is located. Location is not brainstem. Its location is close to the orbit. This is the preganglionic fiber. This is a preganglionic fiber for the ciliary ganglion. It is the fibers of it travel with the 3rd nerve, in which in the nerve to inferior oblique, the fibers of the parasympathetic will be traveled. But they are coming from where? Edinger-Westphal. Where it is located? Midbrain. It's located in the midbrain. Okay. Yes, it's a continuation. It's they relay. Okay, let us see one more question, guys. Again, interesting question. Try to look at this question. I guess this is 6th or 7th question, whatever it is. The 79-year-old man is brought to your office by his wife because he keeps running into things on his right side. Meaning by, suppose I'm walking and there are things on my right side. I'll keep running so that it means that I'm not able to visualize anything on the right side. His wife also states that he seems to ignore objects on his right. I'm not able to, there's some visual field loss. You test his vision in each eye and determine that your patient cannot see anything in the right visual field. Got the point? What do you mean by keep running into the things? Remember that also. That could be a separate question. You order a head MRI because you suspect which of the following. Okay. You test the visual field, you found that the right visual field is lost. Cannot see anything, right visual field is lost. You order an MRI What do you suspect? A pituitary tumor compressing his optic chiasm, a tumor in the medial wall of the right orbit compressing the optic nerve, an aneurysm of the left middle cerebral artery compressing the left optic tract, a tumor of the middle cranial fossa compressing the right optic tract, aneurysm in the arterial supply to the visual cortex. Interesting question. All the very best. Read the question once again. A very good question. I wish you all the best for this question. He cannot see anything in the right visual field. Think. B. Nishant and Ravi are going with B. Okay. Shubham is also going with B. Haren is going with C. Okay. Cannot see anything in the right visual field. Very good, Haren. Now understand in this particular question. These are your two eyes. Fine. This is the, say, the retinal fibers. These are the nasal retinal fibers. They will cross. Fine. These are the, let us make a different color over here. This is the, just a second, yes. This is the temporal retinal fibers. They will be on the same side. Problem in this patient was on which side? Cannot see anything in the right visual field. Okay. So right visual field loss. Right side visual field loss. What does it tell? It tells you that any person standing on the right side, they are not able to see. Meaning by which side there is a loss, they are not able to see, means that this and this. That is that you have a loss of the left temporal hemiretina and the right nasal hemiretina. Okay, and where are they continuing? They are both continuing in this side. That is on the left. And what is this? This is the optic nerve. That is the site of optic chiasma. And distal or posterior to it, you have the optic tract. So right visual field loss, the problem is in the left optic tract or distal to it. If you look at the questions, pituitary tumor compressing the optic chiasm, that will lead to bitemporal loss, not whole the right side hemianopia. Tumor compressing the optic nerve, that will lead to blindness of that eye. That is also not a correct option. Aneurysm of the left middle cerebral artery compressing the left optic tract. Problem was where in the left optic tract. That was the site of the, that would be the site of the problem, you can say, site of the lesion. Tumor in the middle cranial fossa, no, not right. In the right optic tract, it would lead to contralateral. Contralateral means opposite side. That is the left hemianopia, left side hemianopia. Therefore, the answer is our option number C over here. Last question, aneurysm in the arterial supply of the visual cortex. When there is a aneurysm in the arterial supply of the visual cortex, okay, then there would be, apart from macular sparing, the eyes will be gone. You're getting a point. So the bottom line over here is, that distal to the optic chiasm, there is always contralateral hemianopia. Optic tract, optic radiations, there is contralateral, means left optic tract, if there is a lesion, the visual field loss is on the right side, and vice versa, meaning by right optic tract problem, visual field will be on the left side. Okay, so remember, this question is testing 2-3 things. First of all, do you understand this? Keep running. They may now, let me tell you, they may omit this line that you test his vision and you determine that your patient cannot see anything in the right visual field. Yeah, they may just give you that keeps running things on his right side. You order MRI, where do you suspect? So this is just an added benefit to tell you the meaning of keep running things on his right. And then you have to understand the visual tract, the optic pathway. You understood that? Point clear. Job will be done. Fine. So these are a few of the clinical neuroanatomy questions we try to discuss over here. Here again, I want to update. There's a grand test going on from 7th, 14th, 21st, 28th of March. Okay, timing that would be told to you. It is 10 a.m., but that would have been changed. Last mile, that is a plus course. You can join that 1 month, 19 subjects, total revision, clinical MCQs. Plus course, all the best for that. Revise-a-thon. Tomorrow there's an anatomy test of 1 hour, 5 to 6 p.m. If you want to go for the scholarship, all the very best. So these are 2-3 things from here on my side. I will again meet tomorrow, guys, at 10 a.m. to discuss other clinical neuroanatomy questions. I hope you like the session. If you like, give us a thumbs up. Okay, and hope to see you tomorrow. Revise and all the very best. Thank you for it.